Let me try this down. Good. So, welcome to this session on Pediatric Cardiology quiz on 23rd of November 2017. I'm Dr. Prem Sekar, and I bring you this presentation from Chennai in India. I put together about 20 odd slides on quiz today, and I hope you enjoyed as much as I did putting it all together. What I want you to do is always answer the questions specifically. I don't want you jumping the gun. If I ask you for a clinical sign, don't go and give me the diagnosis. I want you to answer the questions specifically. Absorb what you see, take your time, process it in your mind, and then give me intelligent answers. Okay, so we are going to start off with a little teaser of fluoroscopy image here. Take your time to look at that, and the question is, to what course is this wire taking in this fluoroscopy image? Take your time. I'll give you a complete 30 to 40 seconds, and you can answer me. What course is the wire taking in this fluoroscopy image? Okay, it's time to give me some answers now. Yeah, let IVC, should I come here, to RA to EA. Good. So that's the correct answer. We'll move on to, now what I'm going to do is the next 3 slides are angios. There are no questions attached to the angios. I want you to look at all of them carefully, absorb the details, and the question will follow in the 4th slide. So the next 3 slides are all angios. Just have a good look at them and make notes if you want, and then we will answer the questions. And by the way, this is the same child whose wire course you saw earlier. No hurry, I'll give you 1 full minute to see this. And then I'll move on to the next slide. Okay, now I'm going to move on to the next slide, which is the same patient. You can make notes if you are happy to do that. Okay, I think we have seen that enough, and then now we move on to the third slide. Okay, now the questions follow. Which one clinical sign do you think should be markedly noticeable in this child? One clinical sign. Just remember what you have seen and answer this question. No answers so far. I'll go back and play this again. Which one clinical sign do you think is noticeable in this child? No answers. I didn't think it was that difficult. No answers still. So I'm going to go on to the case history of this child. This is a 3.5-year-old male child who presented with central cyanosis and pan-digital clubbing, which was detected at routine school health screening. So the central cyanosis, what do you think the central cyanosis was due to? Now that you have seen the angios, he was a completely asymptomatic child, and the central cyanosis and pan-digital clubbing is what prompted a cardiac evaluation. And on auscultation, he had normal heart sounds. There was no murmur over the precordium and the chest wall. Now I would want to know, what do you think? Yes, Dr. Akshata has replied that pulmonary AV malformations is a possibility in this child, and she is correct. Now with this details, do you think you would want to do any further clinical examination? You have seen the child, you have taken a history, you have auscultated and there is no murmur, heart sounds are normal. Is there any other clinical examination that you would do? What other examination do you think will complete your clinical examination? No answers? I got an answer which is jumping the gun. What I asked for specifically was, you auscultated the chest. Would you do any further auscultation anywhere else? Can't be more clear than that. Good. So finally we're getting somewhere. There was no abdominal or cranial bruit. So see, if I was an examiner and I see the candidates examining a child with central cyanosis, I would like them to see auscultate all over the body, especially the abdomen and over the head, to look for any other AV malformations elsewhere. So this child had no abdominal or cranial bruit. And echocardiography revealed normal connections with no discernible intracardiac pathology. Okay, so we move on to the X-ray and the ECG of this child. Take a look at that. If there's anything you find abnormal, let me know. I didn't think this case was so difficult. Anyway, we'll move on to the angio that we saw earlier, and I'm now going to ask you to list the findings for me. Azygous communication to SVC is one answer I've got. Left IVC is another finding. IVC to the left, RA to RB to PA. Okay. Situs inversus or ambiguous. Okay. I've got about 8 findings in this angiogram. So we've got left IVC, good lung arborization, but dye clearing within 3 cycles, Dr. Akshita. That's good. I've been waiting for that answer for a long time. Okay. Good. So I'm going to list out all the findings one by one. So we have levocardia and atrial situs ambiguous. The reason I'm saying atrial situs ambiguous is because even though the chamber that receives the IVC and hepatic venous flow is on the right and is to the right of the LA, we don't know the morphology. It could very well be of left atrial morphology again. And there is normal AV connections, as you can see. There is absent or diminutive right hepatic IVC. There is hemiazygous continuation to left SVC. There are bilateral SVCs with a bridging vein. If you remember those 3 angios that you saw earlier, there's bilateral SVCs with a bridging vein. Left IVC, you got that correct. Bilateral microscopic pulmonary AV malformations. As Dr. Akshita told, there's dye clearing within 3 cardiac cycles, and you can also appreciate a diffuse prominent blush bilaterally in the lung vascularity. Also, Now we're going to look at, we saw a case of left IVC, and we're going to look at the embryogenesis of the inferior vena cava. We need to know what is normal to appreciate what is abnormal. And if you look at this cartoon, the inferior vena cava develops from three paired venous structures which develop sequentially one after the other, and these three structures coalesce and atrophy in parts to give the four segments of the inferior vena cava. Now, can you name the four segments of the inferior vena cava for me? I know it's pretty basic, but IVC somehow gets less attention than other parts in cardiology, pediatric cardiology. So it's important to know the segments of the inferior vena cava. Name the four segments. No answers so far. The four segments of the IVC. Good. I've got Dr. Akshata, who has given three: infrarenal, suprarenal, and infradiaphragmatic. Now, the four segments are the hepatic segment of the IVC, the suprarenal, the renal segment, and the intrarenal segment of IVC. So these form the four segments, and these segments form from a combination of anastomosis of these three veins: the posterior subcardinal, the posterior cardinal vein, the subcardinal vein, and the supracardinal vein. Now, the first to form is the posterior cardinal vein, which forms around the same time as the heart is forming, around 6 to 8 weeks of gestation. And the posterior cardinal vein drains the venous blood from the body wall inferior to the heart. And the picture you see in green here, the venous structure, is the vitelline vein, which drains the viscera around the same time. And at this time, there's no communication between the vitelline vein and the body wall drainage. So there is no communication between the visceral drainage and the body wall drainage. Subsequent to the formation of the posterior cardinal veins, you have the formation of a pair of subcardinal veins which form medial to the posterior cardinal vein and ventral to the aorta, lateral and ventral to the aorta. And these form an communication between the two pairs, and also form an anastomosis between the subcardinal and the posterior cardinal on either side. So around this time, when this anastomosis forms between the posterior cardinal and the subcardinal, there is union of the right subcardinal vein with the vitelline vein, and and also atrophy of the cranial end of the posterior cardinal vein. So what happens then is the venous blood from the inferior part of the body is shunted through this anastomosis into the subcardinal vein and into the hepatic segment of the IVC. So this basically forms the prerenal IVC at this stage. And once this is done and this part has atrophied, you have the formation of the supracardinal vein on either side, which has again medial to the posterior cardinal vein and lateral to the subcardinal and dorsal to the aorta. And at this point, you have communications developing between the posterior cardinal vein as well as an anastomosis from the posterior cardinal vein to the previously established anastomosis between posterior and subcardinal vein. And once this anastomosis happens, there are multiple communications between the caudal end of the posterior cardinal vein and the supracardinal vein, with atrophy of the caudal end of the posterior cardinal vein, with the result that what you are left with is only the very most caudal part of the posterior cardinal vein, which form the common iliac veins on either side. So those are the only remnants of the initially formed posterior cardinal vein. They form the common iliac veins on either side, and the blood from that gets shunted into the right supracardinal vein. The left supracardinal vein gradually atrophies or coalesces into the right system and disappears. So you have one segment which is the intrarenal segment of the IVC formed from the right supracardinal vein, and you have the renal segment which is formed from the bridging vein between the subcardinal veins and the anastomosis between the supracardinal and the posterior subcardinal anastomosis. That forms the renal segment, and the right subcardinal vein with the hepatic and vein anastomosis forms the prerenal IVC, and the hepatic segment is formed from the vitelline segment of the IVC. So this is where you have the four segments of the IVC: the hepatic segment, the prerenal segment from the subcardinal vein on the right side, the renal segment which forms from an anastomosis of the supracardinal veins and the posterior subcardinal anastomosis, and the intrarenal segment of the IVC from the right supracardinal vein, and the common iliac veins, remnants of the posterior cardinal veins. So it's important to understand this. And when you have persistence of the caudal end, the cranial end of the supracardinal vein, that forms the hemiazygos on the left and azygos vein on the right. The hemiazygos courses up and then drains into the azygos vein when it's persistent. Usually it's very small and it doesn't open up when this venous system is draining normally. So that is the normal embryogenesis of the inferior vena cava, which is normally on the right hand side. So let us see in our case, when you have a left IVC, when you have a left IVC, what happens is you have persistence of the left suprarenal vein, the caudal end of the left suprarenal vein, and disappearance of the caudal end of the right supracardiac vein, and this joins the renal vein. And this is a cartoon where the right subcardinal vein unites with the hepatic vein and forms the normal prerenal. But in this child, this was again not the case. You had the left supracardinal vein going up and continuing as the hemiazygos and draining into the heart, into the LSVC. Additionally, the subcardinal vein was shifted to the left, probably because this was a midline liver. So that is the reason why you see that IVC, the hepatic segment of the IVC from the left going and joining into the chamber on the right side. So this is the left IVC with hemiazygos continuation, and also left-sided IVC with draining into the right-sided chamber. So this is a CT of the same child with which the child was referred to me. This CT was done prior to the angiogram. And this is what the findings were according to the CT: levocardia and delooped ventricles, VA and AV concordance. There's double SVC with persistent left SVC draining into coronary sinus. There's also polysplenia with midline liver, bilateral bilobed lung, left-sided intra-abdominal IVC. So this is the CT findings, and that's the angiogram we have seen. Now the question comes, what additional imaging information would you seek? I'm sure some of you would be thinking about a particular diagnosis. I don't want the diagnosis to be answered. I'm asking you a specific question. What additional imaging information would you seek to substantiate your suspicion of that diagnosis? It's a very interesting case. CT brain, says Dr. Akshita. I was not quite thinking of CT brain, but yes, you could do that. I think I understand the line she's thinking along. Any other answers? A child contrast echo. We don't need a contrast echo at this stage. Contrast echo was done and before the angiogram, and that did show a right to left shunt, and that we have clearly established by angiography as well. So there's no doubt that there are pulmonary AV malformations. I'm looking at the holistic picture here, and with that in mind, is there any other additional imaging information you would seek? This is a 3.5-year-old child who presents with central cyanosis, pan-digital clubbing, and has proven pulmonary AV malformations, microscopic diffuse pulmonary AV malformations, polysplenia, left IVC, and bilateral SVCs. So you have venous abnormalities, you have polysplenia, you have pulmonary AV malformations. Okay, I will give you a clue. Any additional imaging information in the abdomen? Yes, Dr. Akshita has gone there. Right. GI abnormalities. What specific GI abnormalities would you look for? Malrotation. Anything else? Polysplenia is already established finding, so we're not looking at that. Association of polysplenia, cyanosis. Okay, somebody's jumped the gun and given me a diagnosis. I'm looking for a additional imaging information. Can you tell me what specific additional imaging information you would seek for? I'm not looking for the diagnosis at this point. Somebody has got it right, but I want the test that you would do. The same person could answer. CT angio, yes, to look for what? What would you write in the CT angio request? The information that you seek. Good. Finally, we are getting there. IVC to portal connection. Okay, portocaval shunts is what we are looking for. What is congenital portosystemic shunts? List the types and its prognostic significance. Okay, congenital portosystemic shunts are venous shunts between the portal system and the systemic venous drainage. There are basically two broad types, type 1 and yes, Nidhi Kaushal is correct, two types. Type 1 is what and type 2 is what? I hope you're not all searching it off the internet right now. Type 1, type 1 entire supply. Right. So type 1 is where you have a complete end-to-side portocaval fistula, in the sense that the entire portal venous drainage gets shunted into the systemic venous drainage, which is usually the IVC, bypassing the liver. So the entire portal venous drainage bypasses the hepatic circulation and gets shunted into the systemic venous circulation. This is a very bad scenario where the prognosis is grave. You cannot do any other intervention apart from liver transplant. So type 1 is of grave prognostic significance. Type 2 is where you have partial flow into the hepatic venous system and partial shunting into the systemic venous drainage. And this can be divided into, there are some authors who have divided it into 2A, 2B, and 2C, depending on where the shunt arises from. So 2A would be where the shunt comes from the left or right portal vein into the systemic venous drainage. There will be a kind of communication from either the left or the right portal vein into the IVC, and the rest of the blood would go into the hepatic venous circulation and perfuse the liver. And these are usually quite amenable to management. Type 2B are those shunts where the shunt arises between the bifurcation of the pulmonary portal vein and the splenomesenteric confluence. And these tend to be bigger because these are just outside the liver, and these shunts tend to be a little bigger and would be more difficult to manage. And type 2C are from the mesenteric artery or gastric artery or the splenic vein into the IVC. So these are gastrorenal or splenorenal shunts. And these tend to be mostly extrahepatic. Okay, so that is the prognostic significance. In this child, what accounts for the cyanosis? Pulmonary AV malformations. What do you call that? Yes, we know it's pulmonary AV malformations. What do you call the condition where you have pulmonary AV malformation secondary to a primary problem in the liver? Hepatopulmonary syndrome. Okay. And what is the most common presenting symptom of Abernethy malformation. So this child is a Abernethy malformation. PAH says Nidhi Kaushal that is not the most common presenting symptom. The most common presenting symptom is neurocognitive dysfunction secondary to what happens when the portal venous, the splenic vein and the portal vein because of hepatic dysfunction. And what are the management options for Abernethy malformations? Management options for Abernethy malformations? Type 2 device or coil closure or coil embolization. When it's not amenable for these, surgery can be attempted. Unless type 1, as I said, liver transplantation is the option. Okay, so this is an cartoon animation of the portal venous drainage. So, type 2A would be a shunt from either this or this into the systemic venous drainage, whereas type 2A would, type 2B would be a shunt from this segment into the portal into the systemic venous drainage. And type 2C would be either from the superior mesenteric or the other major veins into the renal system. Okay, just look at this and tell me what is the what do you see? Yeah. Okay. Okay, so this is a contrast bubble echocardiography which shows congenital pulmonary AV malformations, and when they are congenital, the pathology is at the capillary end loop, which are the capillary wall is in a minute. It's come, is it? Good. Then we are done. So this is a congenital pulmonary AV malformations and classified into simple, complex, and diffuse. Simple when there is a single feeder artery from a segmental artery feeding the AV malformations. Complex when there are multiple feeding, and diffuse when, like what we saw, diffuse microscopic bilateral PAVMs. And the management you're all familiar with. We just go ahead and plug them up. Okay. So in these congenital malformations, the issue is a defect of the capillary wall, which becomes weak, dilated, and forms these saccular malformations. And just look at this and tell me what is the operation performed here and what is the consequence. Quick answer. What is this commonly known shunt? Okay, so this is a Kawashima shunt, which was reported by Dr. Kawashima somewhere in 1984. He performed the repair in 1978 and reported it in 1984, and is in a setting where the IVC is interrupted and drains into the SVC in a situation of single ventricle physiology, and doing a cavopulmonary anastomosis in this setting ensures that most of the inferior vena cava drainage also goes into the pulmonary circulation. But they come back with pulmonary AV malformations because the hepatic flow is bypassed, and for this reason they develop pulmonary AV malformations and cyanosis, and the management for that is a hepatico-pulmonary conduit, thus completing the fontan, and the pulmonary AV malformation spontaneously resolve. Now, name the condition here. So this is hereditary hemorrhagic telangiectasia. You have pulmonary AV malformations in multiple sites in the viscera, in the lungs, liver, brain, and the most common symptom at presentation is what? Yes. Cyanosis, and what is the most common presenting sign? I asked for a symptom, not sign. The most common symptom. Cyanosis is not a symptom. Cyanosis is a sign. The most common symptom at presentation is epistaxis, repeated nosebleeds due to the telangiectasic lesions in the nasal mucosa, and the most common presenting sign would be telangiectasia. Commonest locations where these are seen is in the lips, the oral mucosa, the fingers, and in the hands. And this condition was erroneously described as hemophilia with telangiectatic lesions and nosebleeds prior to its discovery by Osler, Weber, and Rendu. What are the criteria to be met for diagnosing HHT? There is a Kurakau criteria whereby you have to have a telangiectasia, you have to have a first degree relative with a similar diagnosis, and you need to have pulmonary cyanosis, and you have visceral manifestations of pulmonary AV malformations. So these are the requirements. Out of these 4, if you have 3, that would entertain a diagnosis of hemorrhagic, hereditary hemorrhagic telangiectasia. Now, the last 2 slides, just to look at the pathophysiology of PAVMs, especially in situations like cavopulmonary anastomosis, where the hepatic blood is diverted away from the pulmonary circulation. What happens is you have angiogenic factors and anti-angiogenic factors which are thrown out of balance, with the result that you have a prominence of angiogenic factor expression in the lungs. Anti-angiogenic factors like angiostatin and endostatin are suppressed, with the result that you have an enhanced expression of vascular endothelial growth factors and vascular endothelial growth factor receptors, which again can increase the secretion of vasoactive amines like nitric oxide and other vasoactive substances, which cause dilatation of these end vessels of the capillaries and the venules, thereby forming pulmonary AV vascular malformations and cause right to left shunt. So I hope you enjoyed the presentation today. Sorry about the brief interruption in between, and I've based this quiz on extracardiac cyanotic etiologies. And Abernethy malformation is something which all of you should be well versed with, as it's a condition which is more commonly recognized now and is being more and more diagnosed and managed by pediatric cardiologists and structural interventionalists. So thank you for your patient hearing.